first is that when we're talking about health, as all of us know, and you are such eminent public health activists, and you have so much work and experience that I don't really need to speak like this, but we all know as activists that when we talk about health and when we talk about women's health, there are a range of issues which we are having to deal with. Now, today we are talking very specifically about one aspect of it, which is maternal mortality. And it's absolutely true that this is an issue which does require focus, because quite frankly, the government figures are suspect on this. And in the last year, when we had a very specific discussion on the budget for health, this was one of the issues which many of us had raised. And we got the same kind of answer which has been given to the Special Rapporteur on Health by the government, saying that, you know, it's come down, but there's no evidence really to show that it has come down. What is the evidence? What are the studies? Where is this huge drop which they're saying has happened in Uttar Pradesh and Bihar? But we really don't know where it is. So one thing certainly is the importance of getting correct information and to get at the government and to ensure that we are not misled with complacency. So in a scenario where there are so many competing and equally important aspects of women's health, the first question is, how do we address the importance of the focus of the issue of maternal mortality? I mean, I think it's very important. I don't think it is the only issue. So we have to see it in a more comprehensive way. What is that comprehensive way? What is that policy framework? I think Anand has very clearly said we need to legalize it. We need to bring the law in, and therefore once you have a legal right, and it's not dependent on this or that government, and dependent on this or that cuts in budget according to government requirement, then I think certainly we can include it in a vast range of rights which we are all fighting for. So that is one important aspect, the legal right for protection, the legal right for access to health services. This is one very important aspect which I think, if it's one of your recommendations, and I saw it was a recommendation in the Paul Hunt report, I think that is important, and certainly we can take that up. However, what I am really more interested to understand from all of you is, what is the policy framework that you're looking at? Because at present, why I raise this is that the present framework of the Rural Health Mission and the focus on Janani Suraksha Yojana, which some of you have had, I know, I've seen some of your showed us reports, very frightening and scary experiences of how there's so much corruption in it and so on. But basically, do we accept that we are for institutional delivery or access to institutional delivery? That is one area. Why I want to raise this today with you is because there is a debate going on. Just very recently, in fact 4 or 5 days ago, there was a meeting of the Women's Empowerment Committee, and on my request we are discussing the issue of ashas. So within that committee, there was a strong opinion, particularly from Rajasthan and Madhya Pradesh, that why lay so much stress on institutional deliveries? Why not once more go back to the DICE and the DICE system? And why this whole ASHA, the focus on ASHAs? And I really wasn't very convinced with that argument, because we have seen in the 60s, I mean, all of you know, if you just look at the history of, the lack of access to medical health, this is not in any way to undermine or to negate the very important role that our traditional DICE and midwives play. And certainly we can be looking at ways in which they should be, in a much stronger way, included in this entire system of being able to provide care and maternal care. But I don't think we can say it's an either-or issue. So it's the policy framework today which we really need to look at, and I would really appreciate it if you could give some indication of how you are looking at the various schemes that the government has. What I am very concerned with, and this is some of the information that we have been getting from some of the states, is that in the name of increasing access, the dependence on private insurance. And what is not private insurance, it is the insurance which is linked to private sector care. In increasing accessibility, a woman can go to the nearest private sector unit and her bill will then be paid by the government, which really seems quite right on paper. But the kind of issues which are coming up in that, of course, one is the corruption issue, is a perennial issue with us in all our schemes. And that, of course, we have to fight and confront. But the other is the misuse of that to go in for more and more cesarean operations. I don't really know what your findings are on this, but we are finding that where you're bringing in this point of expenditures and where the government is guaranteeing a particular expenditure for that, this aspect has also come to light. So one is, what are we looking at in terms of policies? So my personal view on this is, I don't think we can just go for one particular system. I think you need to, in a country like India where we have such a high rate of deaths. I saw that figure which I think you have used, 70,000, 70 to 80,000. I think Anand's report has said around 1 lakh deaths. In any case, it's just so horrendously high to think of how many women are, childbirth, being killed, basically. And I really like that point which in one of your papers when you say 1 lakh people were killed. What would be the the result of that? And here, this is these silent deaths which are taking place all over the country, and we're really not noticing it. And I thought that was a very well put point in one of your papers. However, what I say is that in such a situation, I believe that a policy framework has to be a little flexible, and we have to have different areas of approach and include all of them on the basis of the state providing, the state taking the responsibility, certainly, but what are the different avenues or areas? Now, I'll tell you a very practical thing which I found. In many of the remote tribal areas now, the women who are being recruited by ASHA, some of them are traditional midwives now, even though they have not passed class 8. And they have got the training and they're not doing too badly. There may be 1 or 2 cases where they have not been able to provide it. Now we have recommended from our committee that, transporting the woman, getting her there, those things have to be made much more easily accessible and economically viable for those who are responsible for taking the pregnant woman. But now there is a move in the name of giving quality care to past class 8 who's living in that particular village and going to be accessible, and forget it, don't have anything. It's better not to have anything to have somebody who's not a class 8 pass. Now, personally, I cannot agree with that, because I think we can train our women. If you have a rigorous training program, we are not, in fact, even our ENMs now, the importance of child delivery, even in the ENM courses, has been so gravely and greatly reduced. So this is one aspect, the policy framework, and I think we should be clear on that. The second thing is that the money. Now, no, in the policy framework, there's one more point I'd just like to flag for you, and that is this whole targeting system. Because in more and more areas we are seeing that this BPL, APL targeting system, which Anand has said a universal right, you cannot say that you are not going to get that right. You cannot say if you're going to have a 3rd child, you cannot get the right for special care. This is absolutely outrageous and completely objectionable. And I've been crying myself also in Parliament on this, but there is such an obsession with control of fertility rates that they just think that, we're talking a different language altogether. So the very basic human right of a woman, whether she's got 5 or 6 or 2 or 1 child, to have a similar access and economic support to get the best medical care that she can in those circumstances, even that is being taken away in the name of targeting. Therefore, I feel a very important point that we do need to stress when we talk about protection for pregnant women is this doing away with the targeting system and to